It's a fantastic question, and I think if you think about somebody making that trip every day, it gives you an idea of how committed they are to their recovery and willing to do whatever they can do to stay in a healthy place.
Again. Yeah.
Right, absolutely. And so I would say that your question in a sort of larger context is, to what extent does science provide us with medications that could be helpful in dealing with addiction, and to what extent are we utilizing those resources? They're extraordinarily underutilized, and there's still a significant stigma associated with medication-assisted treatment, specifically methadone, which has, again, been a highly researched, approach, and again, I commend the Commissioner for making that more readily available to folks. There are significantly more doctors who are trained to prescribe Suboxone than are doctors actually prescribing Suboxone. And there's also a little bit of a disconnect, and at times, maybe sometimes a significant disconnect, where some physicians who are prescribing Suboxone are not engaging their clients in ongoing treatment other than the medication, right? One of the nice things about a methadone clinic is that they're staffed with clinicians who provide additional services. If you go to a physician, you get Suboxone, hopefully, and it's expected that a doctor should be connected with community-based treatment programs that would be supporting the use of that medication. Frequently, that does not happen, and many times there's diversion that occurs. I would really suggest that we look in depth at this whole issue of medication-assisted treatment and look at why it's being underutilized and what we can do to A, reduce stigma, B, to engage physicians. The New York Society of Addiction Medicine has a good number of physicians who are engaged in doing medication-assisted treatment in their private family practices, and I think they could really be relied on to provide us with some good information. But it's unacceptable. In New York City, they're trying to reverse this issue and try to get more access to Suboxone so that people, frankly, can have treatment that's a little bit more accessible if they're working people, et cetera. And there's also Vivitrol, which is another medication that's starting to make a scene. The Commissioner referenced it for a criminal justice project that's happening. But it's an underutilized tool that really, I think really, it deserves the scrutiny that you're suggesting.
Thank you.
Thank you.
Thank you. Save Our Western New York Children's Psychiatric Center, Stephanie McLean Breathley, Transition Coordinator, OPWDD.
Good afternoon.
Good afternoon.
Committee chairs and members of the Joint Budget Committee, my name is Stephanie McLean Bethley, and I'm currently a social worker with the Office of People with Developmental Disabilities, but I was employed for 10 years as a social worker at the Western New York Children's Psychiatric Center. I've been working with a group of parents, self-advocates, graduates, and mental health professionals in Western New York for several years to oppose a portion of the so-called Western New York Children's Service expansion proposed by the Office of Mental Health. It is my hope that the testimony I have prepared will be given careful consideration and begin a dialogue between stakeholders and members of the New York State Legislature regarding services in Western New York. On behalf of the advocates with the Save Our Western New York Children's Psychiatric Center, thank you for the opportunity to comment on Governor Cuomo's fiscal year 2016-2017 executive budget proposal and its impact on children inpatient psychiatric services in Western New York. Please refer to my full testimony for background on the issue, but for the sake of brevity, I will summarize our request for the preservation of children's services. We have put forth an alternative to consolidating the Western New York Children's Psychiatric Center and the Buffalo Psychiatric Center based on stakeholder input and feedback from the community. Our team has begun to draft a plan to present as an alternative to the consolidation. It has been shared with several legislative offices, the Governor's Office, and the Office of Mental Health. The proposed plan is to create a Child and Adolescent Center of Excellence. This concept would allow children's behavioral health services to remain distinct at the current location while meeting the goals of the Transformation Initiative OMH has drafted as part of the plan for Western New York. These goals are cost-saving, future expansion for community-based services, and the expansion of prevention services. The COE plan will run parallel to the initiatives from the Medicaid redesign team to ensure longevity and adherence to system-wide goals. A Child and Adolescent Center of Excellence will provide individualized, comprehensive, and coordinated care organized for children and their families. The CEO would offer services specifically designed for pediatrics and adolescents that are developmentally appropriate and include innovative interventions to address complex psychiatric problems. It is envisioned on-site programs and providers that would serve individuals with behavioral health disorders, substance use disorders, and eating disorders while offering physical health and rehabilitative services. This would be the first program like this in the state, offering services to the next generation overseen by multiple state agencies. It would also address the service gap of community-based services which are ill-equipped to deal with these specialized issues. This proposal will build and highlight the record of excellence and quality outcomes that have been established at the Western New York Children's Psychiatric Center. This center will offer families a respectful and holistic way to receive services and treatment in Western New York.
Thank you.
Thank you. You've been very good advocates on this issue. We appreciate everything that you're doing, so thank you for being here today.
Thank you. Barbara Crozier, VP Government Relations, Coalition of Provides Associates. The Providers Association.
Good afternoon. Thank you very much. Thank you for your stamina. And we appreciate the opportunity to speak to you. I'm Barbara Crozier. I'm with Cerebral Palsy Associations. I'm here with Winnie Schiff of the Interagency Council. Our other partners, J.R. Drexilius from the Developmental Disabilities Alliance of Western New York and Margaret Rostiello from the Alliance of Long Island Agencies, had to leave to catch a train. But they and also the New York Association of Emerging and Multicultural Providers have gotten together to establish the Coalition of Provider Associations. So we are here on behalf of COPA. COPA was established, we came together last fall because people with disabilities and their families and the organizations that support them are increasingly frustrated by state funding cuts and the lack of investment in our workforce and supports and services. These cuts have caused layoffs of staff, the reduction and elimination of supports and services, and long delays for those seeking entry into the programs. We were very impressed by all of the questions asked by all of you of the Commissioner. You have our written testimony, and we're not going to go into that, but we just wanted to clarify a couple of things. First of all, the OPWDD budget has remained flat over the last 5 years. And I think, I'm not sure who it was who talked about the definition of new and new funding. Commissioner, or Acting Commissioner Delaney talked about a 4% increase and $170 million increase in the OPWDD budget. That, again, it's not new money, it's not new from last year's enacted budget. It is a flat budget over the last 5 years. And actually, when you look at the difference between the enacted budget last year and the proposed budget, there's actually a decrease. So, but I did want to clarify that it has the OPWD funding for and again, this is just aid to localities for not-for-profit providers, but there were $259 million cuts under the Cuomo administration and 121 before that, and since then it's been a flat budget. The last inflationary increases, as you know, were that the legislature was really so significant in enacting was the 2% increase for direct care and then another 2% for direct care. So really over the last 6 years, the only thing we've been able to give our staff is a 4% increase. We want to talk about minimum wage and some other things that are real important.
And actually, since you have our testimony, we're not going to get into all those other things. We're really focusing on minimum wage, which is our biggest issue. Before I begin, I just want to say that we are so grateful for your incredible support. You're so knowledgeable, and we're so impressed about our issues. And thank you so much for that. So the first thing we want to make clear is that COPA absolutely supports the governor's proposal to increase minimum wage to $15 an hour, and to say that, you know, given the fact that there's no money in the budget to do that, we are unique in two ways. You know, this is a problem for lots of providers who rely on government funding, but we have a very large number of low-paid workers, and we also rely nearly exclusively on Medicaid funding, which is 50% federal and 50% state money. As far as, you know, our direct support professionals go, they love their jobs, but they are really difficult. I know this because I have many years as being a DSP myself, and we currently have a very difficult time with recruitment and retention. And so our most the most worrisome thing about the minimum wage increase in this coming budget year is compression. So I want to give you a couple of examples, like on July 1st in New York City, the minimum wage will go up to $10.50, and our higher in rate in New York City is about $10 to $12. So anyone earning $10.50, say, in New York City on July 1st, their salaries will be brought down to minimum wage, even though they have very high training requirements, so much responsibility for people in the programs. They have to have very, very highly developed judgment, and there are serious consequences for making mistakes. In other parts of the state, some of our staff are earning $9 an hour or slightly above that right now, and when the minimum wage increase goes into effect, they'll be brought right down to minimum wage as well. You know, we'll have to give them additional money, even though we are not funded to do that. But the fact is their jobs will be devalued when what they do is so, so important and very, very responsible. As you've heard previously, it will cost us state share only $135 million in order to do it in just this budget year. And, you know, this big discrepancy will lead us to either, you know, cut staff, lower, you know, we won't be able to find staff with as high qualifications, and even now, as I said, we have issues. We'll be able to provide a lot less support to people, and eventually we will have to close programs. So, you know, we are already competing for the same labor pool with fast food, and we're extremely concerned about this and other things, but you can read our testimony.
Right, and all the associations, all 7 associations have been working together, NYSRA, NYSACRA, NYSARC, all of us. We did come out with a report in November that has lots of statistics, and we have a unified statement, and we will be providing that to all members of the legislature as well.
And thank you.
Great, we truly appreciate your
Can I just
testimony.
say one thing? I think it's very also important to explain that because of something like the increased minimum wage, how many people and the turnover in your organizations, and that costs for orientation and learning and testing and doing all the background checks.
Right.
And then what's going to happen is this is going to cost these agencies a tremendous amount of money due to turnover and also frustration. If you are the person that's been there 10 years, you're going out the door.
Right, right, and we've
Exactly.
And I just had to say that one.
we've had 0 increases in order to be able to do all of that.
Right.
So thank you very much.
Thank you. Andrea Smith, Executive Director, New York State Coalition for Children's Behavioral Health.
Good afternoon. Thank you all for staying.
Good afternoon.
I will forego my testimony and just attach to the back of my testimony our talking points about our top priorities. I want to begin with the call to invest in non-hospital community service providers. There's a pie chart for your information about the resources made available to hospitals for transformation to Medicaid managed care and alternative payment methodologies. And in the pie chart is a small sliver of money that was made available to community healthcare providers. So I have joined with other community healthcare providers to ask that 25% of two funding streams that are available to hospitals be set aside to be directed for community healthcare providers, and that would include children's behavioral healthcare providers. Those two are the $195 million Healthcare Facility Transformation Fund and the $355 million Essential Community Provider Pool. And if we had access to 25% of those funds, it would strengthen our ability to change our services to be ready to take the downsizing of the hospital referrals. The second priority has to do with a cut in the OMH budget, a reduction in the startup funds. It used to be $120 million. It mysteriously got reduced to $115 million. Now it's proposed to be reduced to $105. We asked for a restoration of those fundings, and we asked that all $10 million be earmarked for children's startup. Specifically, I point to the fact that not a single child has moved yet from into Medicaid managed care. Not a single exempt children's mental health service has yet transitioned to Medicaid managed care. There is a chart in your packet that shows from the Kids MRT group how many kids would receive the 6 new services proposed in the governor's budget to be funded. And you know, just for your edification, 72,500 children and families are expected to receive family peer supports. And yet we have no ability to build the capacity, hire people, train people, and have them on staff by January 1st to be able to meet that demand. The startup funds that are being taken are really the kids' startup funds. There's no other way to think of it because we haven't gotten any yet. And there is a recommendation that $4 million would be available for startup for children's system, but I just ask you to look at those numbers of how many children and family would receive crisis intervention and how many would receive other licensed professionals and complex psychiatric rehab. And ask yourselves, if you were going to be ready to provide those services on January 1st, 2017 statewide, even at 25% of those numbers to begin with, could you hire, train, and credential people by January 1st and be ready to implement the programs? And I think you would honestly be able to say you would not. Another shortfall for the children's system is really that we have not had the funds to be doing data analytics and identifying how we would measure outcomes if we were moved to alternate payment methods. So we ask for an investment to design a data collection plan and data analysis effort. We want to do this in conjunction with the Conference of Local Mental Hygiene Directors. We think the county children and family directors really are interested in making sure we move forward in the right way on that. And lastly, you can see we have issues with minimum wage, as everyone else does, and want the investment in family resource centers to divert kids at risk of persons in need of supervision placement, be able to give them and their families the type of family engagement and support to really keep them out of the family court system.
Any questions? You can have questions. Any
Senator
questions?
Kruger.
One question.
Senator Kruger.
And not for lack of more questions, just because of time. So the chart is actually too small.
I'll get you a
So just
big
tell
one.
me, you're proposing that 25% of this pie go to community-based?
Not the whole pie. That was $2 billion that was made available to hospitals last year, $2 billion. We're proposing that 25% of these two funds
sub-funding streams
be available to community providers. And the 25% is simply, quick math, 25% hospital reductions, 25% community increase.
And so thank you. So what percentage did you get in year one of these
Approximately 4% of that pie chart went to OASS or behavioral health providers. 4% of the whole pie.
Thank you.
Yep. Thank you.
Thank you.
Thank you very much. Just for the people watching on TV or on their computers, I had said we'd be starting the hearings for the workforce development at 5 o'clock. I'm moving it back to 4:30. So we're suddenly moving much faster than we planned to. Next, Pat. Ed Snow, Labor Management Offer of OPWDD. That's it. Huh? Now you can ask your question. Yeah, I don't believe you. You left.
Thank you, committee members. My name is Ed Snow, and I represent OPWDD and PEF. I'm the labor chair. Also with me is Virginia Davey, who's the Office of Mental Hygiene labor rep for the Labor Management Committee. Originally, I was supposed to testify for both, and I'm really not the expert in the OMH field, so I'm here for the OPWDD side. You have my testimony in front of you. I really wanted to kind of touch on some key points of that testimony. I have worked in this agency for 30 years. I have seen the agency go through a lot of different changes. The new word that we call that is the transformation, and the transformation has certainly been benefit for some members that we serve. People have certainly lived a better life in the community, and that is a good thing. One of our concerns is the situations that were not positive and that were kind of the people who fall through the cracks. And we express that concern to the agency when we meet with them on a semi-annual basis. We express our concerns on a continual basis as professional employees regarding those failed situations, because usually we find that the failed situations are tragic, that they really are truly a failed situation that we believe as professional employees could have been prevented. The other thing I wanted to touch on is that the transformation panel is a panel that PEF does not sit on. We talked about today from the commissioner that it's the stakeholders. Our colleagues from CSEA has one member on that panel. The Professional Employees Union has never been asked to have a representative, and we actually are the people who are the professional employees within the agency. The other issue I wanted to touch on is something I've heard from people today, and it's about the Justice Center. And I understand that they're not here. I've seen a lot of questions asked of the commissioner about the Justice Center. From our point of view as professional employees, we believe that the agency has a role in the Justice Center. We also believe that there needs to be a better review on the practices of the Justice Center and the things that they do within their job and their scope of doing business. Our members oftentimes get tied up with false allegations because our members are professional employees who hold licenses. They often get tied up with licensure issues. They also get tied up with a very hefty amount of money they have to spend to defend themselves in that area. So that is an area that we believe needs to be looked at. And, I've heard people today ask a lot of questions about it. It seems to be an agency that has a lot of questions and not a whole lot of answers. I'm going to turn over my time now to Virginia.
Why, thanks, Ed. I'd like to just echo the same issues that Ed brought forth as it relates to the Justice Center. We've heard of great disruptions to the treatment milieu related to people being extracted from their work environments, particularly with people who have mental health challenges. They are counting on us to be the consistent provider, the person that they can count on to be there from day to day. Often these children or these adults come from families where they've already been shipped all over the place and they have to get to know a new face. And I think so, it can't be discounted how much that type of change, simple change, can impact the lives of people in treatment. So that's another avenue. The other thing is that what I often hear at my labor management committee meetings, the downside of the transformation plan. And I want to take a moment to thank you very much for your advocacy, your 90 90-day guideline for the facilities to use before they vacate a bed. I would caution all of us to take a very good look at the numbers when we're seeing whether or not the 90-day mandate has been met. Sometimes there are practices that would allow a facility to put beds on reserve to help them to look vacant. There are times when emergency rooms have been full of 4 and 5 referrals because a bed has been cut at a facility because it's no longer needed. The irony is amazing, and it greatly, in fact, impacts the patients that we serve to have to send them off to different areas for treatment. So I think that's the biggest and most important, because that most affects people who are in critical level of crises that actually need us to save their lives, inpatient treatment. We have to make sure that the gaps are filled before those beds are taken. And that's going to take a concerted effort actually looking at all those numbers. We're having tremendous recruitment and retention difficulties in our facilities related to nursing, related to psychiatry, related to psychologists, and they are the whole backbone of the services that we provide. So increasing any reinvestment funds or funds wherever we can get them to help to maintain that backbone of the system is really where we should initially focus a lot of our energies. The other thing is that the increasing caseloads. I'm hearing in a lot of these different presentations that there are no waiting lists. There may be no waiting lists because the counselors have been giving ungodly levels of caseloads. We do not want to treat people with an eyeball to see whether or not they're okay or not. We want to be able to sit and talk with them. These people with mental illness are real people. They deserve something more than a prescription, something more than a glance. They need to have treatment that's meaningful and is of high quality. And I think that's where your public employees come in. They are all licensed, certified, and tried and true providers of mental health services. And I think to the extent that we can use some of our reinvestment funds to reinvest in something that you know has worked and will work in the future, is to continue to invest in your workforce. Instead of having 150 people on a caseload, expand your OMH services to provide more counseling capacity. We're finding that a lot of our counselors are concerned about professional ethics and whether or not they're stretched to the limit. So we really want them to be able to walk away from that job feeling as if they've done a good service for the people that we provide services to. I very much appreciate your indulgence today. And I look forward to answering any questions that you might have. And also, there's nothing in our world in PEF that is more important than providing services to people who cannot advocate for themselves. And that's why we're here today.
Bronson, you want to go? Yeah. Ms. Gunther.
Thank you very much for waiting so long. First of all, I think that PEF should be on the transitional committee, and we can talk later, Ed. And secondly, the 150-person caseload. And if I'm thinking about a week, 2 weeks, 3 weeks, how long of a session could a social worker have with that person that's therapeutic enough, and getting to know somebody takes long enough, and getting somebody to trust you? So that caseload is absolutely too high in order to have an impact on these folks and keep them out of inpatient services. The only way you do it is good therapeutic, and I know you're trying your best, but 150 caseload is unbelievable. So I just want to bring that to the attention of those that are taping this.
Yeah, and the standard used to be years ago 45, and we know we have to push the envelope. All of us are pushing the envelope. But when you have social workers, psychologists, psychiatrists, nurses coming to you and saying, I'm concerned about being able to work here anymore.
Well, it's your
Right.
license on the line.
The license on the line.
Assemblyman Avenatti. Oh, sorry, Senator, excuse me, hold it.
Yes, Senator Savino, please.
Thank you, Senator Young. Continuing on the same theme, so I guess the recommended caseload would be about 45
Well,
clients, roughly.
I'll tell you that the caseload is so determined by the acuity level that it really depends. If you have a really high needs group, then your capacity should be on the lower side of things. If you have people where you're just, as I said, eyeballing them, I think you might be able to eyeball 50, 75, 100. But if you really want to treat some of these people who are the ones that are most likely to get out and be on their own, ones that talk therapy will help them, that all of these skill sets that we try to teach them will help them. Those are the ones that we want to make sure that they get their talk time as well.
I think in the next hearing that's coming up, we'll probably focus a little bit more on this issue, because it's really about workforce issues. I think most of the agencies now are down to the lowest level they've been in 30 years. And the caseloads obviously are going up with the reduction in headcount. The commissioner of OPWDD or mental health didn't talk about the FTE reductions this year. We expect we'll hear something later on, but I'm assuming there's been attrition, and as you said, people are leaving because they don't want their professional licenses to be affected because of the level of the workload. What is the current status of headcount? What is the headcount right now?